Hello guys, this is Intisar from Medifectious, and this will be a brief overview about Kawasaki disease. Before I continue, I want to say that this is a part of our my medical elective virtual program sponsored by SDocs, powered by Magnetic Academy, and that it is also a something you should not use as part of overriding any clinical judgment. This is just for an educational piece that I hope you learn something from and take something away from it. So what exactly is Kawasaki disease? It's a rare systemic vasculitis. What does that mean? Systemic meaning all over the body, vasculitis or vascles or vessels, itis meaning inflammation. So these vessels start becoming inflamed, and when vessels become inflamed, they can start thinning, reducing the diameter inside the walls, making it harder for blood to travel to areas that it needs to. And potentially it can lead to aneurysms, and with aneurysms, if they rupture, they can cause hemorrhaging, but not just rupturing, but aneurysms in general. With this sort of inflammation that you're getting, and you get narrowing of these the diameter here, you're going to get less blood flow to where you need blood to go. So who does it really affect? It usually affects children of 6 months to 4-year-olds, but it can affect them up to 5 years old. It usually affects Chinese people more, as seen in the name Kawasaki disease, more than African Caribbeans and Caucasians. Why is it that we should worry about this? It can lead to aneurysm of the coronary artery, and this could lead to heart attacks and sudden death in children. It's one of the commonest causes of acquired childhood heart disease in the developed world at the moment. What are the sort of classical features of Kawasaki disease? Well, if you are seeing someone that has a fever more than 5 days, you should suspect Kawasaki disease. It's part of the NICE guidelines. And the other features that you're also looking out for is irritability and your redness, swelling, or peeling of the skin, and bilateral conjunctivitis, essentially sort of irritation in the sort of eyes, and or rash. So I want you to just pause the video right here and look at these signs that the 2013 NICE guidelines have put in. So not this one, we'll talk a little bit about this later, but just what are these signs? What are you looking at in terms of, and when you give the signs, say the signs in the medical word, not the sort of layman's term, if you are a medical student or a doctor watching this. So I'll just pause it here. Okay, so you should have had a pause and try to guess what these are. So here we can see bilateral conjunctivitis, and that can occur for 80 to 90% of people. Usually there isn't any exudates. Here you can see what we call a strawberry tongue appearance of the tongue. They have maybe changes in their oropharyngeal mucous membranes. You might see some enanthema, and an enanthema is actually an ulcer or sort of eruption in them, sort of mucus secreting surfaces inside the mouth that you might start seeing. So you might see ulcers there. Here you can see what we call a polymorphous exanthema. So an exanthema is when there is a rash relating to a fever. So you get a polymorphous exanthema. Here you can get desquamation of the sort of distal areas, and essentially peeling of the skin. You usually see unilateral lymphadenopathy, and it can occur in around 50% of people, and usually it's in the anterior triangle that you usually see it in. Diagnostically, it's usually, as I said, this is all sort of clinically, this is how you would diagnose it. So as I'll go to the next slide in just a little bit, but essentially these are the features that we're looking out for to say yes, this person definitely, most likely has Kawasaki disease. But this clinical guidance is still under scrutiny at the moment, so it might change in the coming years when new research is found about this. In terms of investigations, because it's an overreaction of the immune system, you will see a high ESR, high CRP, high white cell count, and given in the second week you might also see a platelet rise, so you might want to do a platelet screening here. You might want to also do an ECG and echocardiogram, but because it might be you're seeing Kawasaki disease patient in a later term, and actually you do need to do an echocardiogram to see that. So diagnostically, this is what they've mentioned. This is from patient.info. And this is what they've mentioned. So the inflammation or irritation of the lips that you're looking at, so that strawberry tongue, erythema, edema, or desquamation of the extremities that you see, bilateral dry conjunctivitis. It's important it's dry, not wet. Widespread non-vesicular rashes, so essentially the polymorphous exanthema I was mentioning before, and the cervical lymphadenopathy that you might see, which is usually quite large. What are the other causes of prolonged fever that you might still need to be aware of? There are so many reasons that you could have a prolonged fever, and Kawasaki is just one of them. But it's something you still need to have in mind. But given the history, and you found that with this there is a prolonged fever and there's no potential other causes, then Kawasaki disease becomes higher and higher up in the list. But you do need to make sure you rule out the localized infection, deep abscesses, TB, viral infection, which are probably better treatable, and you need to make sure you find the right cause of that prolonged fever before coming to the conclusion of it potentially being Kawasaki disease, because you don't want to give them the wrong treatment after all. So what are these sort of phases of Kawasaki disease? How do you see what they see? So you might see in the beginning, actually, with Kawasaki disease, the fever actually lasts for a very long time. It lasts in the acute phase, in the subacute phase. And you start to get these sort of thrombocyte count could go up as and that's why actually in the treatment you might see why aspirin is used. Arthritis is sometimes seen, and so the cardiovascular system, which you're worried about, aneurysms, are usually seen after around mid of the second week. It starts becoming more and more prominent. So this is why it's pretty important to detect it earlier on, so we don't get this aneurysm and more complication when we don't need to, if we can treat it earlier on. And obviously the other changes as well. So this is just a overview of the acute symptoms that you will see, and these are the sort of subacute symptoms that you see, and this is where most of the sort of the dangerous period is actually, because you get thrombocytosis, and you get all of the coronary artery aneurysm, MIs, all of the problems start to occur in the 2 to 8 week period. So this is why it's important between the 5 to 14-day period that we should find out about if they have Kawasaki or not, because we can potentially save a person from dying. In terms of the long-term sort of effects, you may still get some aneurysms happening, and cardiac dysfunctions, infarction may still occur in the future. As I said, this is you can try and treat it now, but you never know what happens in the future. So they're more likely to get it. You might start getting Bowles lines, so these sort of nail systems, nail file infarcts that you'll see. You can just, I haven't got a picture here today, but you can search up online what Bowles line look like. But it's an uncommon, as I said, it's very uncommon to see Kawasaki disease. So it's uncommon to see someone with sort of Bowles line. But yeah, you might see that. If incomplete Kawasaki, then what do we do? So let's say there's a patient and they have the symptoms, but they're not perfect. It's not perfectly aligned with what the American Association has said about it. So they've also come up with other things to look out for. So if they have a fever of 5 or more days and they have 2 or 3 compatible clinical criteria that we mentioned before, which are these. So these clinical criteria. If these clinical criteria are not met, and let's say they only have 2 or 3, but you think it could potentially be Kawasaki, what other things can we be looking out for? So if they said if your CRP is quite low, then look for perform serial clinical and laboratory evaluation. If keep doing it to see if especially if the fever is persisting, and do an echocardiogram, especially if feeling is developing. The echocardiogram is really, really important because we want to see if there is a dilation of these coronary aneurysm or not. So we want to do a positive and echocardiogram. But you can look at these other signs as well. So, for example, anemia, platelet count being high, the thrombocytopenia that we were talking about, sorry, not thrombocytosis that we're talking about. There might be a high, some raised ALT, albumin level might have decreased because of inflammation. So any sort of inflammatory processes will always decrease your albumin. Remember this is quite important. White blood cell counts might be high. Urine white blood cells count could also be high as well. So these are just things to look out for. What in terms of treatment do we do? So in terms of treatment, we're looking out for giving aspirin or IV immunoglobulins, and if they do not work, then you can have these other potential treatments. But at this point in time, you've potentially diagnosed it and you've given the treatment that you needed to give. But then it comes up to the pediatric registrars, because this will be because this is sort of quite a rare complication, and there's a lot of other complications that to deal with. You would want to escalate to a pediatric registrar or a consultant who will be better able to help you understand this condition better and treat it better. The problem is with, for example, aspirin, there actually isn't a lot of evidence behind saying it should be used. There is obviously the problem with aspirin, because if someone is quite a young kid is taking aspirin, they may develop Reye syndrome, which we're usually Reye syndrome. So we're worried about that. So we need to take that into consideration as well when we're giving this treatment. There isn't the best of evidence for aspirin, but the thinking behind it is because aspirin has the antiplatelet and the antipyretic effect, which is important in this scenario here. What about the coronary aneurysm? If a coronary aneurysm occurring, as if you're a junior doctor or a medical student, obviously you're not going to be doing anything here. You got to get the pediatric cardiologist involved. They have their tools available. For example, they will decide what will be the best course of action for them. For example, thrombolysis, ballooning, cardiac stents, ablation therapy. And depending on the severity, some do even require coronary artery bypass, which is quite sad to see. And in terms of long term, if they do have it, they may get warfarin, but there might be other long term plans. It depends on the cardiologist and any of the other complications. So, but warfarin may potentially be needed. So hopefully from all of this, you've learnt about Kawasaki disease. You've learnt about what it is, what it is, what the treatment plans are, what you should be looking out for, and what are the bigger complications, and who should you to escalate it to. So to finish it off, I want you to do a quiz for me, and I will leave the link and things. The quiz is on anything that I've talked about already on my slides. It will be blatantly obvious. I'll try and make the quiz as easy as possible. I just want to encourage quizzes because active learning is the best way of learning. In terms of any other further information, so I got most of my information from the Illustrated Book of Pediatrics and the patient.info site for Kawasaki disease. I hope you enjoyed this little tutorial that I made for Kawasaki disease, and if I make any other videos, I hope you join and watch it too. Thank you. Bye bye.